Thank you so much. Good afternoon. It's a pleasure to talk to you this afternoon. I'm quite delighted to be sharing the stage today with Professor Ghosh. This is an event that's related to inflammatory bowel disease, and I'd like to thank the organizers and thank AbbVie for inviting me to this event. So let me start with a case from our center. This is a 22-year-old gentleman, known case of Crohn's disease, fistulizing Crohn's disease, A2, L1B3, which means that he was diagnosed beyond the age of 16 with purely ileal disease and fistulizing behavior of his illness. He was diagnosed in his local hospital in 2015 when he was treated with conventional treatment with steroids and immunomodulators in the form of thiopurines. He was first evaluated in our clinic in mid-2018. We performed colonoscopy. This is a picture of his terminal ileum showing ulceration and inflammation. More proximal to that area, he had a stricture. And indeed, cross-sectional imaging showed inflammation of the terminal ileum. In addition to that, he had a fistula from the ileum to the sigmoid colon. And this is the endoscopic image showing the opening of the fistula in the sigmoid colon. We initiated therapy with adalimumab in mid-2018. He received the usual loading dose, followed by the maintenance dose. On subsequent clinic visits, he showed significant improvement. He's attending school regularly. His Hardy-Bradshaw index was only 2, indicating clinical remission. He scored 2 points for having 2 loose bowel movements per day. His investigations on his most recent clinical visit showed anemia, and his CRP was 45 compared to a baseline of 113. His fecal calprotectin went down from 1200 to 435. So the question before us this afternoon, in this patient who's 22 years old, in clinical remission on adalimumab with high CRP and fecal calprotectin, should we escalate therapy? Professor Ghosh will be arguing for treat-to-target approach, supporting escalating therapy, and my approach will be to advance an argument for clinical management. My argument will rely on 4 important pillars. First, the natural course of the disease. Not everyone with Crohn's disease will progress to complication. The second pillar of the argument is that treat-to-target is a really nice concept, but how applicable is it into real practice in this country? The third point this afternoon is that there is this association between clinical symptoms and disease activity. And finally, when I recommend escalation of therapy for my patients, what are the chances of this escalation succeeding? So let's start with the epidemiology of the disease. This is data from the EPI-IBD study, published in print in this month's issue of Gut BMJ. In it, researchers from 29 European countries looked at 488 patients over a 5 years period. These patients had Crohn's disease. As you can see shown here in blue, the majority started with inflammatory type Crohn's disease, and 5 years later, they remained in the inflammatory category from 71% to 61%. Only a minority of those patients progressed to more severe form of the disease, stricturing or penetrating disease. So not everyone with Crohn's disease will progress into complications. The second point about clinical practice, I don't know about your practice, but in my practice, one of the challenges is that patients are not that adherent to their medication. So if I start escalating therapy, based on inflammatory markers without checking the patient compliance, I may be giving them more aggressive immunosuppressive therapy than someone who wasn't compliant with the initial plan. The CALM trial, which Professor Ghosh will discuss this afternoon, advocates for increasing therapy based on clinical symptoms in addition to non-invasive monitoring. So patients with high Crohn's disease activity index are recommended to have escalation of their therapy. My concern with this is that we know from data from the ACCENT-1 and SONIC trials that not everyone with active clinical disease will have objective evidence of inflammation. Indeed, 18% of patients with clinical activity of the disease had no objective evidence of inflammation in their endoscopic evaluation. And the same applies the other way around. Patients may have active inflammation without symptoms. My fourth and last point in my opening statement is that the effectiveness of therapy is an important thing to discuss with your patient. When I recommend escalation of therapy to my patient, I have to be honest and frank with them on the chances of this escalation succeeding. We know that anti-TNF therapy, while they're great and changed the way we practice inflammatory bowel disease, they are not perfect. 1/3 of patients are estimated to have primary non-response. of those who respond to initial treatment, 1/3 will lose response over time. So I'm worried that when I recommend escalation to my patients, it might not be successful. So there are pros and cons for early intervention, aggressive escalation of immunosuppressive therapy, including maybe changing the outcomes, clinical and endoscopic remission, disease modification to the hard outcomes, including surgery and hospitalization. You get better efficacy for TTNF if you start them earlier on. But I think we need to think about the cons of this approach, including the safety of these medications, and we'll talk about it later on in the rebuttal, and the cost of these biological treatments, which are quite expensive. And finally, the lack of randomized controlled trials supporting this approach. So this concludes my opening statement. I'll give the floor back to Professor Ghosh.
So thank you for inviting me to Jeddah, which I came after 6 years. I'm amazed about the change. Thank you for having me here. So I think the case that Dr. Al Ameel presented is a very important one, and this is something that we face almost every day in our clinical practice. So these are my disclosures. There are several issues to consider. Now, I have listed some of the issues here, but the most important issue is what Dr. Al Ameel showed us, that there is a dissociation between clinical symptoms and objective inflammation and disease progression. In the study, the EPI-PD study that Dr. Al Ameel showed, 22% of patients had surgery over the 5-year follow-up, and 36% of patients were hospitalized. And in that study, patients who were on immunomodulators, on biologics, had less hospitalization and less surgery. So this is an important point. Of course, adherence is very important, and in a patient who's not adhering, making them adhere to the drug by proper support and counseling itself is a kind of escalation of therapy. But the CALM study was designed to see how can we make our current therapy, in this context biologic therapy, become more effective. So the treat to target design was patients with moderate to severe Crohn's disease who were started on prednisolone, and then they were randomized either to CTAI and prednisolone use arm, clinical management arm, or to the tight control arm, which in addition to CTAI and prednisolone use had fecal calprotectin and CRP. The threshold for fecal calprotectin was 250, the threshold for CRP was 5. The randomized study then had an option to escalate therapy starting from week 12 based on pre-specified criteria. First step was introduction of adalimumab in induction dose, followed by 40 milligrams every other week. The second step at the 3-monthly follow-up was escalation to 40 milligrams every week. The third step was introduction of azathioprine, 2.5 milligrams per kilogram, on top of the adalimumab. There was also opportunity to de-escalate therapy if the patients achieved biomarker or clinical target. This is the characteristics. Now I will point out only 3. First, you will see that though patients up to 6 years of disease were eligible, because the patients had to be bio-naive, immunomodulator naive, and free of complication, the actual disease duration before they entered the study was very short, 1 year or less. You can see their mean CDAI was quite high. Most of the patients had elevated CRP and or elevated fecal calprotectin. This was what was seen at the primary efficacy endpoint, which was mucosal healing defined by CDIS and no deep ulceration. And you can see that the tight control arm, driven by fecal calprotectin and CRP, most of them were driven by fecal calprotectin, was better than clinical management arm. Now remember that this is a strategy study. This is not an efficacy study. For an efficacy study, it might have required a more clean start at the beginning, and then perhaps a longer period of time for most of them to have the chance to get into mucosal healing. There were multiple secondary endpoints. The most important was that for the most relevant endpoints, like clinical and biological remission, the patients on tight control arm did better than the patients on clinical management arm. You can also see that if you looked for endoscopic response, then you did even better, as you would expect, in the tight management arm. But clinical management arm for endoscopic response also did quite well. Patients started to become steroid-free and in remission by CDAI from as early as week 11. And at week 11, tight control was better than clinical management. You can also see that the time to flare was longer with a tight control arm than clinical management arm. In fact, you can see there were quite a small number of flare-ups in the tight control arm. You can also see a very important endpoint which will eventually relate to cost to the payer, was that hospitalization and after randomization was lower in the tight control arm compared to the clinical management arm at week 48. You can see here the hospitalization and serious complication rate, and this at week 48 tended to be higher in the clinical management arm. Tight control arm was better. It didn't reach statistical significance. You will see the further follow-up data which was done for this study by tracing these patients, and these will be presented at DDW, which will show that even this endpoint after longer follow-up becomes significant. Now, this biomarker study was preceded by a clinical target study called the REACT study, which was a cluster randomized study. So the REACT algorithm was driven by Harvey-Bradshaw index-driven remission. And after start of steroids, if at week 4 the patients did not reach clinical remission by HBI, they were started on biologic and immunomodulators, adalimumab, but they could also start on infliximab if the investigator chose to. If the patient went into remission on steroids but relapsed, then they would also go on biological therapy with adalimumab combination with immunomodulator. They are followed up every 3 months on HBI, and you can see at 24 months there were many meaningful endpoints which were better in the early combined immunosuppression treat to target type arm compared to the clinical management arm. So surgery rate was lower for early combined immunosuppression, serious complication rate was lower, and hospitalization, surgery, and serious complication rate, a composite endpoint, was also lower when it was driven by a treat to target strategy using clinical endpoint Harvey-Bradshaw. The POCR study was another treat-to-target-like study, but in post-operative Crohn's disease, to look at treatment of endoscopic recurrence. So the patients after surgery were randomized either to conventional management without endoscopic control or to endoscopic control with a colonoscopy at 6 months. Initially, everybody received metronidazole, and high-risk patients received thiopurine, and if intolerant, biologic. At 6 months, if they had Rutgers I2 or higher recurrence by ulceration, they will then go on to treatment with biologics, adalimumab. This was the result. And if you look at the deep blue color on the left-hand side, you can see recurrence rate at 18 months with the active management arm, colonoscopy controlled, was 49%. The recurrence rate with the standard arm, clinical management, no colonoscopy control, was 67%. This was statistically different and in favor of colonoscopy as a control process, as a treat to target at 6-month intervention. So, my final slide is simply a summary of how we are evolving from symptom-driven treatment to objective control of disease, and then how, now and more in future, as we get data, we can talk about disease modification. This is important because progression of disease is an important factor. The APIBD study, inception cohort, showed about a 14% progression from B1 to B2 or B3. There are other studies that show a much higher rate of progression. For example, the Fernando Magro, my colleague, published a large cohort, 778 patients, 87% were B1 disease. And in 51% of their patients with a longer follow-up, up to 12 years, 51% of patients had progressed to stricturing disease or fistulizing disease. So this is still an important problem. So I'm going to stop now, and then we'll resume the debate, and I will hand over to our chairman.
So Professor Sobrata, if you can have a seat here. So just we'll continue the debates with the three questions in the debate from now. You could use the other, so you can just press this one here. So the first question is, can we justify the cost?
So that's a convincing argument that Professor Ghosh made, and the question I have in my mind when I propose such an approach in my practice, as I'm sure you do, Uthman, is the cost of these medications. We know that inflammatory bowel disease is quite an expensive disease. This is from a white paper published in the AGA, estimating the cost of the disease to be 1.7 billion in the United States. So this is an average of 12 to 20,000 US dollars per patient per year. And we know that 18% comes from the 18% of the sickest patient consume 80% of the cost. So that's expensive. When you break down the cost based on the COIN study published in Gut in 2014, you see that the majority of the cost comes from anti-TNF therapy. They were the only biologics available at that time, and I'm sure this continues to be the case with current biologics. 19% hospitalization, productivity loss is significant. Surgery cost was less than 1%, so it's not that expensive. More importantly, sustained remission was achieved in 10 to 20% of patients without medications. So how can we justify the cost in these patients?
So this is an important question, both for healthcare providers, but especially for the doctors and payers of an organization. So it is very important to realize that a smaller proportion of patients results in the biggest cost. So these complicated patients require the biggest cost. So this is the data from the CARB study, analysis of incremental cost effectiveness ratio. On the left-hand side, you can see the actual direct costs, and on the right-hand side, you can see the cost, the quality of life. So 1 point equals to 1 year of perfect health. That's how it is calculated. So you can see the calculation of the cost and the quality to show whether the incremental cost is overtaken by an incremental benefit to quality of life, the so-called incremental cost effectiveness ratio. And you can see the cost effectiveness ratio, the incremental cost effectiveness ratio, here was about £10,000 per quality. It was calculated by UK costing, because the UK cost increased cost because it is increased cost per quality, but it also results in this because it reduces hospitalization and potentially surgery in order to follow. So I'm just going to skip this slide, but come to this slide, which is the same APIBD slide that was shown. And one of the conclusions of this slide, exactly like the core study, is that our cost of using biologics is increasing as you would expect, but in spite of the increasing biologic, the APIBD study confirmed that there was a cost saving overall to the health system because of saving in surgery and hospitalization rate in this inception cohort study. So I will stop here and take any secondary questions or further debate.
So we will be focusing today, and the next part is the treatment targets and safe approach for treatment.
So as we said, if we use a treatment approach, we end up consuming more biological therapy. And the question of safety is an important one. We were alarmed by the publication of this population-based study from France last year, of 2017 in January, with 90,000 patients, insurance-based data, and they compared patients who had IBD, exposed to high alone, and TTN alone, or the combination of the two. What they found is that the combination therapy, which is commonly used in treatment target approach, leads to more diagnosis of lymphoma. This is the adjusted hazard ratio for high monotherapy 2.6, similar rate with TNF inhibitors monotherapy, but to combine both agents, you end up with adjusted hazard ratio of more than 6. The same group published their data looking at domestic infections, gastroenterology 2018, and again, combination therapy led to more domestic infections compared to high monotherapy or anti-TNF monotherapy.
So in the top study at week 48, the treatment target arm, which required more biologic adrenaline, compared to the clinical management arm, there was no difference in safety signals. Now this is a 48-week readout, so the safety signals that are most relevant here were the infective, the serious infection rate, and this was no different. For signals such as development of lymphoma or non-melanoma skin cancer, we need a longer time. But we know that in general, almost all the safety studies show the risk of non-melanoma skin cancer tends to be driven mostly, if not exclusively, by the thiopurine use, but not by the biologic use. For the lymphoma risk, again, the biggest risk is driven by the thiopurine use rather than by the anti-TNF therapy used as a monotherapy, though the latest JAMA paper, which is the largest one, showed a small increase also in lymphoma risk. But remember the way the CARP study was conducted. It was monotherapy adalimumab first, followed by monotherapy with an increased dose of adalimumab, followed by introduction of azathioprine if needed. And one of the reasons for this is the DIAMOND study conducted in Japan, which showed that the clinical efficacy of monotherapy adalimumab was similar to combination therapy of adalimumab with azathioprine, which means that adalimumab tolerates monotherapy better than some of the previous biologics, though of course, like all biologics, it has got some immunogenicity. So, generally speaking, giving increased biologic alone does not lead to an increased safety concern. But it is completely right, and as Dr. Al Ameel suggested, that a combination therapy has got safety issues. And in my practice now, when I first start a biologic, especially for moderate disease, I often consider a monotherapy approach first.
So what about the last just about could you just explain this treatment just looking at biomarkers without going to the endoscopy or for patients?
So can we just use biomarkers to drive therapy? generally speaking, if you have a raised biomarker like caliper above 250 or CRP above 5 or below, and this does not come down to the normal level, which has to be a level that is considered to be compatible with the remission, below 250 or even below 150, this can really try and make sure that this works and this is effective. So you can try different biomarkers. So in the CALM study, you can see that this was looked at and that endoscopic remission and biomarker-driven remission were very close to each other, especially for fecal calprotectin, but also to some extent for CRP. You can see that in the sub-analysis that fecal calprotectin below 150 and slightly better if it's fecal calprotectin less than 150 or 250. So 250 is adequate, 150 cutoff is probably a little bit better and relates to endoscopy. What happens to patients who don't even have fecal calprotectin available or their fecal calprotectin is never raised? In these patients, I think endoscopy becomes useful, or potentially other things that we use, like transabdominal ultrasound scan, which in future might be used more in Saudi Arabia also. So you can do it only with biomarkers, especially fecal calprotectin, but some patients will have a gray zone calprotectin at the beginning, like between 100 and 250. These patients need checking with endoscopy for sure.
Thank you for such excellent debate, especially for Dr. Al Ameel and often you are doing the fecal calprotectin.
Well, I suppose for clinical management. So the answer is we do it in 12 weeks. The patients who are just initiating good treatment, but the patients who are stable, we do them every clinic visit, which is every 6 months. I wonder if that's good practice to learn.
I think that is every 12 weeks was how CALM was organized, and also we saw clinical readouts reactors every 12 weeks. So I suggest every 12 weeks for calprotectin measurement. Once you have brought your calprotectin down to below 250, now technically often it is below 150, so there should be remission, then I start reading every 6 months, and that is quite adequate. So this would be perfect. In a patient who has been in remission like this for 2 years, more than 2 years, 3 years, then it is probably you can go down even more and simply do it at the clinic visit every year. That's also okay.
Professor Ghosh, nice to see you again. I always enjoy the debate, and also Turki is a very nice debater. That's what we see about T2T, treat to target. So it is patient-centered, not doctor-centered. So what Turki is saying, that clinical response, clinical remission, and then you set the target to the patient. Fecal calprotectin and CRP should be normal. And then the question comes always to reach to these targets, optimization of therapy, and the trough level and the antibodies. And the mucosa healing at the end of the day, we are reaching 30-35%. We are not reaching our goals. So setting the target, patient-centered should be our aim, and we tell him from the first day. So for optimization of therapy, do you do the drug trough levels and antibodies, and you adjust the dose regarding even the new biologics? Optimization to reach to your target.
So I will deal with this in 3 points. First one you raised is very important, and you always ask So if I just tell a patient that the target is to normalize fecal calprotectin, it has no meaning for a patient. So the patients need to understand the reason for doing this, just like other diseases like diabetes and hemoglobin A1C, that the calprotectin has a meaning in terms of their active disease in their gut, which, even if they are feeling normal, within 1 year or 2 years, has a higher risk of leading to complication and surgery. So that's the first point. Second point is the compound population, where a patient is actually responding to drug. Just like Dr. Al Ameel's case, the patient has become better from being symptomatic to asymptomatic. But the calprotectin is still high. These patients don't need therapeutic drug level monitoring. They simply need dose escalation. And this is also the HDA guidelines, because these patients need more drug. This is different from patients with a loss of response or a primary non-responder, where we do need to measure therapeutic drug levels to optimize it. These patients can be optimized on biomarker alone. But the last point is very important. My patients now come to my clinic because they understand that generally the fecal calprotectin, when it is high, and increasingly now we don't do a colonoscopy if it is high or very high, they will realize that it always related to their endoscopy appearance in the past. When we did it, because the calprotectin was high, we found they had active endoscopic ulceration which they could see. So they don't come to my clinic and say, Doctor, I saw my results and my report, and my fecal calprotectin was 800, now it is 62. Isn't that good? They start that conversation. And they do that because they understand that that number has an important meaning.
Yes, so I did a point that was made earlier on about fecal target. And I wonder if we're having a problem not practicing to reach it. So I wonder why is the clinical practice different than this? We know that in this country, not many people are on largest, of course we know. And there is disconnect between clinical practice and what's intended by the fecal target approach. Now we don't have much data from this country, but this is a way for seeing, imagine, looking at clinical practice in the United States. Among patients with community bowel disease who require treatment, the chance of them receiving biological therapy is less than 1%. And those who require second-line therapy, less than 2% take biological therapy as a treatment. This shows the number and percentage of patients with Crohn's disease and the providers on biologics, which I assume are following the fecal target approach, compared to those following on biologics. As you can see from the graph, most of the patients are not on biologics. So this is the United States. I imagine our practice is not that different. How can we explain or justify the disconnect between clinical practice and this approach to fecal target as supported by experts in the field?
Now, very, very important point. The OECO data is an insurance-based general data from the US. I travel in the US not just to the big centers, but I travel to all the small centers and community hospitals in the US. And biologic use can be very low there, and it is driven by the insurance eligible patients. So that the US public is predominantly an insurance problem rather than a requirement problem. If you look at the demand duration paper, the NPID, you will find that most of the time, even in the previous NPID, about 33 to 36% of patients tend to be on biologics in Western Europe. In Eastern Europe, it tends to be low, and that again reflects the availability their perspective of biologics. So I think the important thing is that we don't consider treatment target as an exclusive biologic therapy strategy. I think this is very important. Whenever we treat a patient and start them on steroids or start them on azotherapy, to see whether these patients have come into objective remission. And if they haven't come into objective remission, we consider whether we can escalate therapy. And one of the first ways of escalation is increasing drug.
question for Dr. Subrata. As you know, the fecal calprotectin is good in case of inflammatory phenotype and colonic involvement. However, in EL, it's sensitive specific, and in other phenotypes like fibrostenotic or BNA. So can you comment on how your strategy in this condition?
Again, a very good question. I'll also ask Dr. Al-Ameel to remind me on that. In the dark side, aerial Crohn's disease patients behave in a very similar way for fecal calprotectin as a colonic disease. And you can see that the aerial-only patients behave in a very similar way. So it worked in aerial disease. But the number of patients, you can see here, the left side of each of these is aerial only. And that works there. But the numbers are small. And you are right that you will find some isolated aerial disease where fecal calprotectin is never raised. Now, remember that if it's never raised, then you can't use it as a biomarker. That's the basic answer to it. And you have to use other things, which could be endoscopy, which could be MRI, which could be also transabdominal ultrasonography. So you have to do something else if the fecal calprotectin at baseline is not present. This is not right. The same is for CRP. If CRP is not high at baseline, then you can't use it as a biomarker. The CALM study was selected for patients who had raised CRP and raised calprotectin as a biomarker at entry. So maybe Dr. Al-Ameel, you can just explain it.
Yeah, so this is what we do. We take the baseline fecal calprotectin and as you would do case of the person. And if it's high, we continue to follow it in patients with isolated small bowel disease when it's not raised, then there's probably not much point regularly. I would like to mention here that probably a key target concept does not rely only on fecal calprotectin. There are other non-invasive measures, maybe not included in the current type, things like small bowel ultrasound, for example, which many gastroenterologists in the field of IBD are using now. It's a point-of-care test, has been shown to be effective in the first trial from Germany, where it was associated with the Harvey Blood index reduction in these patients with respiration failure. So the concept of fecal target is probably not limited to fecal calprotectin or CRP. It includes other objective measures of inflammation in these patients.
Any further questions? So maybe we'll just maybe at the end we'll ask how we define mucosal healing. What are the things that we should do to define mucosal healing? Is it only calprotectin? Is it endoscopy? Do we have different agents to do these things?
And then, just before I give the floor back to Professor Bush, it's confused because most of the studies of data provides define mucosal healing based on the partial image score. But when it comes to the definition in Crohn's disease, we know that different trials have defined it differently. So the question in clinical practice, what do you do and what should we do to identify patients with mucosal healing in this population?
So, for trial purposes, this is still a major controversy. And that exact definition of SESCD for mucosal healing is still being debated. In clinical practice, I think it's best to make our life easy. And we go back to the old definitions of mucosal healing, which is essentially a lack of ulcerations, especially deep ulcerations, on colonoscopy in the disease-affected area. So I simply use disappearance of ulceration as mucosal healing, and I accept a certain number of small aortic ulceration to be still left behind, and still accept that as mucosal healing, especially in the small aortic ulcers are 5 or less. Now, I think if you define colonoscopic mucosal healing as such, you will find that fecal calprotectin relates to it quite well. But if there is a discrepancy between patient's symptoms and calprotectin, I think it is still important to do a colonoscopy because you will find some patients where there is a discrepancy between the patient's symptoms and their fecal calprotectin level. But for clinical practice, keep it simple. I actually score SESCD in my clinical practice, but you don't need to do it. If you describe it very well, basic components are mucosal being abnormal, the surface area that is affected by ulceration, and also the presence or absence of stricture. And you saw a beautiful picture from Dr. Al Ameel with an SCSCD score, which is a good way to track it. But you don't need to do it if you are not comfortable with doing it.
So maybe while people maybe have a further question, maybe Turki could tell us what happened to your patient, how did you manage him, and how do you treat this patient?
Well, actually, we argued today, I argued for intervention. We tried to do in our practice therapy to target. So this particular patient, we did therapeutic drug monitoring. What we found is that therapeutic range adalimumab level in our drugs. So he was switched out of class after discussion about this in the team meeting. And we're following him up. We're thinking that he may have surgery down the road. But as it stands now, we switched him to another allergy out of this.
So